Good morning, everyone. Welcome on this beautiful summer day. Happy to see everybody and really delighted to have our two guest presenters here this morning. We are going to be hearing, after we cover a little of our introductory matters, from Dr. Jamie Gradis, the director of the new BU School of Public Health Center for Trauma and Mental Health, something much needed and much anticipated. And she is going to talk about the work of the center, whose mission is to bring together researchers, clinicians, students, community members to focus on public health strategies to identify vulnerable populations and prevent adverse health outcomes. So I'm looking forward to that. And Dr. Zaiming Shen, who is an associate professor in the Department of Community Health Sciences and the Department of Epidemiology at the BU School of Public Health and a faculty partner with the new center. And Dr. Shen was the lead author of new research this spring on the implementation of post-overdose programs being associated with a decrease in the opioid fatality rate. So both very relevant to what we've been talking about and just some new information for us. So I want to thank both of them for joining us this morning. I also want to thank everyone on the task force who joined us for our June meeting when we heard from Dr. David Holtgrave from the White House Office of National Drug Control Policy on the steps that the White House is taking really to address the increasing dangers being posed by xylazine. And you'll recall that last month we also heard from Laura Laley from the Newton Wellesley with an update on the work of that community collaborative. And I'm excited to share one update that relates to the training and those topics we talked about last month in a moment. But first, and this is really both for Dr. Gradis and Dr. Shen and for anybody who's joining us for the first time, as we continue to grow this task force and bring new members, I really want to recall a little bit how we started. As many of you will remember who are our original members, in 2012, we saw a really dramatic, and I mean incredibly significant increase in our overdose deaths, particularly in the Lowell area. And we began this task force and seated it at Lowell General Hospital, really wanting to do two things. Number one, realizing that this was a problem that was going to require a community intervention. And second of all, wanting people to be clear that we saw this as a public health as well as a public safety issue. And that is why we were doing it at the hospital. We then grew that task force to other areas of our very large county. We have 54 cities and towns, 877 square miles, many different issues, and ultimately expanded to 5 hospitals across the county. And trying to really be community specific in terms of some of the things we were developing. Obviously, during COVID, we consolidated those 5 hospital groups to this virtual approach and continuing to have representatives from law enforcement, healthcare, emergency medical services, social services, child welfare, schools, and government. And it's just been an incredibly dedicated group that has done such good work. And as committed as we are to really looking not just at the numbers and the progress we've been able to make, but what the individual stories are behind those numbers. We've been very fortunate here that we were, when we began, after beginning in 2012, to really drive down the numbers of overdose deaths in this county. We saw, as the rest of the state did, a little bit of an uptick during COVID, but we've been able to drive those numbers back down. But we begin every meeting really acknowledging that every death is too many. And also that even if you think about somebody only being connected to 5 or 10 people, that death is magnified so many times by the number of people who are impacted. So in terms of what we are seeing, and we'll put a little map up across our 54 cities and towns and our 1.8 million people, we see that decrease that continues, fortunately, right now. Since our last meeting, we have experienced 17 additional deaths across our county. And as you would expect, they are scattered across all of our cities and towns, with the only city having a number over 2 being the city of Everett, where we had 3 overdose deaths in this last month. And in the cases where the narcotic substance involved has already been identified by the lab, all of those deaths that we've identified have involved cocaine and fentanyl. So we have many that we don't have the results from, but that's what we know so far. And in looking at the human story, we continue to see that common thread. It is people deeper in their addiction for the most part. Many of these folks over the last month were in their 40s or 50s. The majority of them were found by family members or coworkers after a well-being call. Almost all of them were back, and this is a concern obviously because of the level of isolation, we're back using again alone in their own homes. And the other piece is it re-emphasizes the message that we have worked so hard to get out, which is of family members and friends checking on people, the importance of people in a home where someone they love has been using or has a history of use, having Narcan available. And particularly in that situation where they hear what they may not know, but we know to be distress breathing, that they are making that call to 911. And the CDC has put out a list again of those cautions. We'll put that in the chat for people again. And, you know, the polysubstance use, again, as I mentioned, the cocaine and fentanyl, that poison drug supply is really just, it's been reflected in the Massachusetts public health reports, and we are seeing it here. 93% of the people who died in Massachusetts last year, whatever substance they were using, it had been tainted with fentanyl. So that effort has to be enhanced in many ways. And then if we can show, Madeline, if you can put up that map, we can see where we are versus where we were last year. You can see here the communities that have experienced an overdose, and as well by the color coding, what we know to be the substances in those most recent deaths. And we have continued to see, and this is also concerning, and particularly for this new center, I'm hoping will be a focus. We have continued to see, while the numbers overall have gone down, we have seen a pretty significant increase in the number of deaths that we were able to classify on very hard evidence recovered at the scene as having been someone who died by suicide. So that number has ticked up significantly, and we only classify it that way, for instance, when there's a clear note or something is found by our troopers. So that doesn't account for the ones that maybe are also someone taking their life and dying by suicide, but we just don't have enough information by that. So our overall numbers are down by a pretty significant amount. Our people dying by suicide is up by a significant amount. The update that I wanted to share that I talked about earlier is, you will recall last month when we hosted the training on xylazine, we heard about the promise of fentanyl test strips and xylazine test strips as a harm reduction strategy and a tool. So I am happy to report that we have purchased literally multiple thousands of those strips, which I would like to get off my shelf. So I am happy to give them to anyone who would want to make them available. If you reach out to us either in the chat or after today, reach out to Madeline. We will figure out how to get those to you, but please, we have a very significant number of them. And the sooner we use that supply, the happier I will be, and we will be happy to replenish it, especially as to the xylazine. And, you know, I mentioned the substances. We are seeing even marijuana tainted with fentanyl. So people need to be thinking about what they're using, and even especially if they're buying from somebody else or, you know, using somebody else's product, using these strips can literally save their lives. So this is a real harm reduction strategy. So I am happy at this point to, oh, good. We're already having people looking for it. So we'll figure out how to get those to you, and give us an idea of what you think would be a good first start for you in terms of numbers, and we will supply those. So at this point, I am going to turn it over to Dr. Gradis and Dr. Shen, and then we will, of course, come back at the end and talk about what's going on in the community. But I turn it over to both of you, and thank you again for being here.
Thank you so much for having us. It's such an honor and really incredible to hear about the initiatives and the work that's happening. I would love to at some point hear more, and also continue to think about ways we might be able to partner together on these issues. So really, thank you so much for having us. Just going to go ahead and share my screen. So as DA Ryan mentioned, my name is Jamie Gradis. I am the director of the new Center for Trauma and Mental Health at the Boston University School of Public Health. But it won't go into presenter mode. Okay, there we go. I am also an epidemiologist and a researcher myself. I'm a professor of epidemiology in our epidemiology department. My area of research is psychiatric epidemiology, so trauma. I also particularly focus on suicide. So that was a really interesting statistic that you just mentioned. And recently, last year, published a paper in the American Review of Public Health talking about how, people have been saying the suicide rate is going down. It's really among white people that the suicide rate is going down, and it's actually either staying the same or increasing among all minoritized groups. So I think that's an important thing to be focusing on at this point. So I'm just going to tell you a little bit about the center, the goal of the center, the goals of the center, and then I'm going to turn it over to my colleague who will tell a little bit about his specific work in this area of opioid use and opioid death prevention. So a little bit about sort of the catalyst for a Center for Trauma and Mental Health at a School of Public Health. It was really the year 2020, which I think changed us all in a variety of ways. Of course, the pandemic followed quickly by the murder of George Floyd. And in 2020, I was interviewed by Scientific American, and the interviewer said to me, what can we do for people who are experiencing stress and trauma on this mass scale like we are currently experiencing? And it's such a direct question. And I had a very direct answer, which is nothing. Like, we don't have a system in this country that is set up to deal with mass stress and trauma like we experienced in 2020. Psychiatry in this country is largely a crisis-based system. You have to be pretty sick to get help from anybody. And that conversation and everything we went through in 2020 was really the catalyst that got me thinking about the fact that we should be framing these things more as public health issues rather than the clinical issues they've been framed as to date. And I'm going to talk about that a little bit more too. So the catalyst didn't come out of nowhere, actually. I realized after I started really thinking about it that I had things swirling around in my mind related to framing trauma more as a public health issue, really from the time that I got to BUSPH as a faculty member. So here you see pictures of all things that are currently considered traumatic events, natural disasters, sudden unexpected death of a loved one, serving in the military, particularly combat, sexual assault, physical assault, car accidents. But as I spent more time at BUSPH and I heard people giving talks on various topics that affect the public health, I started to think to myself, well, that seems like trauma. That seems like trauma, or at least chronic stress. So some of the things are global warming, right? Like we talk now about that there is actual global warming anxiety and people that are worried about the fact that this is actually happening, this is coming. It feels like individually there's little we can do to prevent it. And is global warming, even outside of being in a natural disaster, at least a chronic stressor, if not to some people, depending on their context, a traumatic event. And sure enough, research has shown that particularly for people who live in low-lying areas, vulnerable people, marginalized people, people in third world countries who are going to need to move due to rising sea levels, mental health symptoms related to this are already a significant concern. School shootings are another example. Technically, unless you are actively in a school shooting, unfortunately, that is not a traumatic event. But as parents, so we all worry every day that we send our kids to school that these things are happening more and more. And where does that fall within our overview as a field of what stress and trauma are? It's not traumatic. It may be stress, but it's significant stress. It's not something that is, has historically been, I should say, part of the stress of everyday life. And then finally, political unrest, sort of things that make us all as a country feel a little bit worried and anxious about where things are headed. All of these things are in this sort of gray zone of things we don't consider trauma, but certainly are now having an effect on our everyday lives. So some other facts just to go through in case anybody on this call is unfamiliar, and other things that I was sort of thinking when this all came together for me in 2020, trauma is actually incredibly common, even with this current stricter definition that we have and use clinically that doesn't include things like political unrest, like worry about climate change, like worry about school shootings. Worldwide, over 70% of adults experience a traumatic event in their lifetime. And actually, most people recover following trauma. It is typically the case that right after a traumatic event, people will experience post-traumatic stress disorder symptoms, almost 100% of them. And then over the next couple of months, they begin to recover and they go back to a normal level of functioning. But a substantial proportion experiences those symptoms, those post-traumatic stress disorder symptoms, long-term, in addition to other psychological distress. And these are the people that don't recover from a traumatic experience. So in the US, the prevalence of PTSD is about 6%. It may be higher now. Some of these prevalence estimates are a little bit old and we don't have data for new ones. And really in the literature on trauma and PTSD, or on trauma, I should say, PTSD has sort of been the main focus as the psychological disorder that we would expect after trauma. But there's now research that shows, including some research I've conducted, that every psychiatric disorder is more likely after trauma: depression, substance use, which I'll talk about more in a minute. Across the board, psychiatric disorders are more common among people who have had traumatic experiences. And so even the fact that the literature has focused mostly on PTSD kind of leaves gaps where we don't know about people who don't get PTSD but get other disorders and how they function. And of course, you all may know, you may not know, trauma and post-traumatic mental health are associated with a large number of short and long-term health problems. I myself have done research showing increased risk of cardiovascular disease, gastrointestinal disease, cancer, dementia, infections, early mortality, suicide. Essentially, trauma, and particularly if you develop post-traumatic psychopathology after, are very bad for every part of you. And so this is a major, major public health problem, given how frequently these events occur. But trauma has historically been treated like a psychological problem, kept sort of in the clinical psychology space where the definition of trauma and the definition of PTSD have been made and really not been as present as a public health issue. And so that was really all together the foundation and the catalyst for the center, really highlighting stress and trauma and their many potential negative effects as public health issues, and fostering a community of researchers, educators, and public health practitioners at BUSPH who are committed to addressing trauma in all forms in conjunction with external partners. So to bring it now a little bit closer to the topic for today, to talk a little bit about trauma and substance use, there is a well-known, strong bidirectional association between trauma, post-traumatic mental health, and substance use. People who experience trauma and PTSD often turn to substances to cope. This is a sort of modified quote from a now 20-year-old paper saying several theories have been proposed to explain the common co-occurrence of substance use and PTSD. Self-medication theory has received the most empirical support to date. That's still true 20 years later. It's the idea that people who experience trauma, experience negative post-traumatic mental health, maybe don't seek care right away for a variety of reasons and begin to use substances to cope. And that leads to then comorbid substance use disorder. And these people then are on a sort of difficult trajectory to eventually become healthy again. And then people who use illicit substances may be more likely to be in situations where trauma risk is increased. So in a small study of injecting drug users, 27% of participants were re-exposed to a traumatic event in each month of the 16-month study. And by the end, 72% of participants had another traumatic experience in the 16-month study period. So there is this really, really important relationship and real entanglement between trauma and substance use that I think is at the heart of many things that can be done to address these issues. So now I'm going to just talk a little bit about some other opioid research that we have going on at BUSPH from some of our other investigators. As I mentioned at the beginning, this isn't really specifically my area of research, but I thought it would be great to speak a little more about the other work that's happening. And then, of course, I will turn it over to my colleague Ziming to talk about his specific study that I believe was of interest to you all. So we have a new faculty member named Noel Vest. Noel is a formerly incarcerated scholar who is also in recovery, and he advocates for social justice issues and public policy concerning substance use disorder and recovery and prison reentry. And he's currently funded, he has an excellent study going on to study collegiate recovery programs and what works in collegiate recovery. And I would say, you know, if you have any interest in this, he would be a great person to have come speak. He has obviously life experience. He's very passionate about these issues. And collegiate recovery is a complicated issue because colleges are places where abstinence is pretty stigmatized. So there's, you know, a lot of interesting work going on there, and he's leading the charge on a lot of it, honestly. Just a recent paper that he's had published that may be of interest to you all: Trajectories of Depression Among Patients in Treatment for Opioid Use Disorder, a Growth Mixture Model, Secondary Analysis of the XBOT Trial. Rachel Sago Adams is an associate professor in our Health Law Policy and Management Department. She's a health services researcher with expertise studying substance use, disparities in treatment, and morbidity and mortality outcomes in high-risk populations. She's done a lot of work on military and veterans, and she's done this really interesting work at the intersection of traumatic brain injury, right, which is a traumatic event that could lead to a diagnosis of PTSD, but it also has this physical health component where people are often prescribed pain medication, particularly in the VA. There was a long period of time where people with traumatic brain injury were being prescribed a lot of opioids. And so it leads to this very complicated situation where people have the PTSD diagnosis because of the psychological trauma and are already sort of being led to this path of potential substance use disorder through the prescribing of opioids for the pain. So she's done a lot of really interesting work at that intersection. And one study, as an example, is diagnostic profiles associated with long-term opioid therapy in active duty service members. Jake Morgan is an assistant professor in our Health Law Policy and Management Department. His work is focused on how best to support patients by promoting access and retention to medications for opioid use disorder. He's currently involved in several funded projects on preventing opioid death and naloxone distribution strategies. And a recent paper of his is the role of increasing pharmacy and community distributed naloxone in opioid overdose epidemic in Massachusetts, Rhode Island, and New York City. Michael Stein is a professor and chair of our Department of Health Law, Policy, and Management. He's done quite a bit of work in this area over the past 2 decades. His work has been at the intersection of behavioral medicine and primary care. His outcomes research has moved between substance use disorders, HIV/AIDS, sleep, pain, mental health disorders, and the determinants of risk taking. And a recent study of his is the impact of COVID-19 and rapid policy exemptions, expanding on access to medication for opioid use disorder, a nationwide Veterans Health Administration cohort study. And then before I turn it over to my colleague, Kristen Strombatny, Dr. Strombatny's research examines the link between risky health behaviors and chronic disease development across the life course. She recently led a study looking at the effect of a predictive analytics targeted program in patients on opioids, a stepwise clustered randomized trial. So with that, I'm going to turn it over to my colleague, Dr. Ziming Zhuan, who is here to talk about a recent study of his that was published in JAMA Psychiatry. It's a really great work looking at the association of implementation of post-overdose outreach programs with subsequent opioid overdose deaths among Massachusetts municipalities. And with that, I will stop my share. I'm certainly happy to take any questions before we turn it over, or wait till the end and we can both take questions at the same time. Either way works for me.
People have questions at this point, you either want to put in the chat or raise your hand or raise your physical hand and just join in. We've got a lot of people here, so I'm trying to slide through the screen, so feel free to speak up. All right, maybe we'll move and then do, people still have questions or think of them, put them in the chat, or we'll take them at the end. Doctor. All right.
Okay, great. Yeah, thank you very much for having me. I just look at the number of participants. There are 80, so it's really like a full house. And thank you for making it such an important event, and great to be part of the conversation. My name is Ziming Shen. I am a professor in the Department of Community Health Sciences, also in the Department of Epidemiology, Buell School of Public Health. I'm a social epidemiologist, and by saying social epidemiologist is that I'm less interested in biomarkers. I'm more interested in modifiable social contextual determinants, including interventions and policies that we can do as a whole to provide a public health intervention to improve individual health and also the well-being of communities. And you know, I really appreciate DA Ryan in your opening statement talking about the severity of opioid crisis. You said that, you know, every death is too many, and every death is connected to the family members, the community neighbors, and everybody in the community. So, you know, the way we want to intervene should really place individual in the context, right? In the context of where they live, who they live with. And I think this is really one of the essence of this outreach program, where we have this partnership between law enforcement and public health professionals. Many of them are, you know, running, you know, harm reduction programs. They work together. They knock at the door of those who experience recent overdose events, and see, you know, what they can help. And then they talk to the survivor. They also talk to the family members, the person who is in the immediate social networks, and see how they can work together, either to provide Narcan, how to train them to use, so they have the potential to be a potential bystanders when an overdose occurs. They also can link them to services, medication or otherwise. So this is really sort of like the foundation, the motivation of these program, and it has been proliferated for a few years, and there is little evidence about how it works and whether or not it is effective. And that is really what motivates us, our team, through a grant funded by CDC to investigate, you know, whether this post-overdose outreach program works in terms of reducing the community level opioid fatality, but also overdose rate in general. You know, so let me see. Everybody's looking. You get the slide there too? Okay. So this is what has, you know, what has been evolving in Massachusetts over several waves of these ongoing opioid crisis, beginning 2000 and all the way to 2020. You know, it's been drastically increased from 2012 all the way to 2016, and we see some plateau of the rates start bending, but you know, the COVID doesn't really help in any way. Back in 2021, we again reach 290, and I also got from the most recent data release that the number for 2022 has about, you know, 2,357. So that's about 300 more than what we have in 2020. Fentanyl played a big part of this increase. We have over 93% of death involving fentanyl. And among cities in Middlesex County, for example, Waltham is one of the cities that experienced a drastic increase. So just to put this number in the specific context of this conversation. And this is what I alluded to in terms of the, you know, the rate of opioid related death and the percentage deaths involving fentanyl. We're getting really close to just around 42% in 2014 to now vastly exceeding 90%. The latest count is 93. So given it's more fatal, it's really important to have, what the Ryan talked about, the fentanyl strip test to ascertain whether the substance involved fentanyl. So a little bit background about, post-overdose outreach. We understand from the literature that those who survive a recent overdose is at actually the highest risk for subsequent fatal and non-fatal overdose. And, this is somewhat similar to opioid, somewhat similar to suicide, for those who have recent non-fatal self-harm attempts are the ones that who have highest future attempts as well. So we see this as an opportunity to engage recent overdose survivors and the social networks, and try to establish a practice protocol to engage, public health practitioners and law enforcement to work as a team to do this outreach. We understand that there is a gap, that a lot of these are underserved populations, and there is substantial amount of underreporting. So by conducting outreach, we hope to be able to uncover, but then to able to provide all the necessary intervention that we have, programs for those that may not be universally available, or they are not for whatever reasons, including stigma that Dr. Gradis talked about, that they will go out and reach and receive treatment that they may need. So this is a very much a community-based engaged research that we have been working on, and we can frame as a really a public health intervention rather than more of a clinical outcomes that that we initially try to differentiate and talked about. So before we really start to evaluate the program, we want to get a sense of, the the proliferation of these outreach programs in Massachusetts. So as part of the funded study by CDC back in 2019 in the spring, we conducted this statewide two-step process of trying to really see the lay of the land, so to speak. We did a screening survey asking, a sample of 1,321 individuals who is affiliated with these community-based outreach program. We have very simple questions, and the main one is, does your organization have an outreach or referral program for people who recently had an overdose, or people who had high risk of having overdose that occur after the overdose event? So this is post-overdose. So we define it very clearly. And people are very eager, and they participate. We have at least one individual from every municipality, 351 towns and cities in Massachusetts, who give us information. So with that, we follow up with those that really have these programs. So we provide a more detailed online survey tool that covers, a number of characteristics items that we want to get to know, about the design, the structure, and the operation characteristics of those programs about 6 months after the initial screener. We sample a total of 157 individuals who have more intimate knowledge about their outreach programs. We have very good response rates, about 88% of identified programs. And here is a summary of some of those characteristics of their programs. So most of them started after 2015, but some of them started really early, like 2014 or later part of 2013. And this is important because this really tells us, the moment they start, we can create some really nice and rigorous, what we call interrupted time series analysis, to see what's happening before and what's happening after, in terms of how the level of the overdose changes, and how fast or slow they change over time. So those are two important characteristics that we actually utilize later for this published study. But in general, we got a sense that the majority of the team consists of at least 2 members, and almost all of them have a police officer. Most of them have a recurring coach or someone who provide harm reduction service, and some are medical professionals. And where do they get the data? The majority of the data are provided by the police department, and then about 50%, a little more than 50% has supplemental data in terms of raw ones that they have. And we have data about the events that we respond to, covering non-fatal and fatal. About 80% either non-fatal or fatal. We have most of the known adults, the overdose survivors. We approach the community typically with a marked vehicle. We are sensitive that bringing this extra undue attention may have an impact to the respondent, and whenever we are present in the house, we always want to engage the social network members, including the family members. The conversation is usually quite brief. We don't want to add extra burden to overdose survivors, and these are some of the characteristics that the post-overdose outreach services provide. Almost all of them involve referral or providing navigation to addiction treatments that that the outreach team would think would be appropriate. A lot of them include a specific provision of opioid overdose prevention services, including providing the Narcan and the related training. They also, if needed, provided mandated treatment processes as they determine in the circumstance. They also provide bereavement support in case there is loss. And so those are the characteristics. I mean, overall, we tend to think that these are relatively new outreach programs that formed between 2016 to 2019. And that's all like the end of the study published. We would like to continue this study and have received funding from CDC, because we want to see whether COVID has changed the way we interact, we communicate with the survivors, because in-person outreach during COVID was not possible. So we want to explore the characteristics of these new like remote outreach or virtual connection, whether those are feasible and have been done in these communities. And we found that these, the response by the partnership between police and recovery coaches to the community has been rapidly changing, using, the new investment, but also existing infrastructure. And so the rate of increase of these outreach program, has been really changing a lot in the past few years. So we are very curious about what would be the optimal practice in terms of the composition of the team members. Are there any concern about the best practices of having the team, and what will be the structure of the team? And we also realize that people of color, youth, they are increasingly using opioid during the pandemic. So we want to provide more patient-centered approaches that is more geared towards this type of unique characteristics of the patient population. So in general, there are a good set of qualitative findings. But my main question that this paper tackle is whether or not these outreach program have been effective in terms of reducing the community level opioid overdose rates. And so like I alluded to, because of the survey of these communities about the timing or the onset of the outreach program, we can frame this as a really interesting natural experiment. So in our study, we look at 26 quarters spanning from 2013 to the second quarter of 2019. There are 351 towns and municipalities in Massachusetts, but our evaluation includes only 93 municipalities. And the reason we selected them is because we want to focus on the towns that already experience somewhat high level of opioid overdose, because it's a prerequisite of intervention in this type of outreach, right? There needs to be some level of ongoing opioid overdose burden in the community before the outreach would take place. So we selected based on 30 or more opioid overdose emergency responses in a single year, in the year of 2015. And but just by these 93 municipalities, it covers a total of 66% of Massachusetts population and 78% of all fatal overdoses. So we cover really a majority of Massachusetts participants and communities that really contribute a major proportion there. And as alluded to, about 3/4 of these 93 municipalities, they have the outreach program established since 2016. So we have, considerable towns that are part of the study. And but as you can imagine, there are towns that would, start around the same time, but other towns may start later. So we have this time varying inception that we need to address and take into account in the study design. So it's quite a complex study design. These are our main hypotheses. The two really key words is level and slopes. So by means level is whether or not having this program could result in an immediate change in the overdose rates. And slow means how it evolved over time, how the fatal overdose rates change over time. So as the time continues, as the program continue to evolve, how it affects the post-overdose rates. Our hypothesis is that because it requires a partnership between the law enforcement and the public health professionals, so there are a lot of things to work out, the team dynamics, the procedures and all that. So we don't really think that, just by establishing a program, it will see an immediate decrease of the level overdose. But we believe that, treating this as a public health intervention, focusing on the highest risk of the population, and then also affecting the social members' readiness to intervene, it takes a time. But when it happens, as time evolves, we believe that this program will result in a decline of the opioid overdose rates. We focus on two outcomes. One is the primary outcome on opioid fatality rates, so it's the most severe outcome. And then we're also curious about this program would not change the opioid emergency response rates. So we use what we call an interrupted time series analysis. So basically, it's an approach that would compare what happened before the onset of the program to after the onset of the program, but taking this type of seasonality, because we use quarterly data, so there is some type of seasonality that we need to account for. And then the analysis also accounts for a large number of community level factors, like the composition of race, poverty level, education, and we also account for community level vacancy rates, which is a sign of deprivation, for example. So we have a set of procedures that will allow us to account for all of these factors. And I just want to show you quickly about these rather very technical outputs. There are two rows here, separated by what I call the level change that correspond to whether there is immediate decrease. And then the slope change is how it evolved over time. So in statistics, we typically look at what we call the p-value. So we have three sets of models here, right? Base model, adjusted model 1, and adjusted model 2. And what we can focus is on the p-value that would suggest whether the finding is statistically significant. And you can think of whether, the statistical significance is a way to judge whether the program is effective or not. Okay, so the row that I have highlighted are the one that regards the slope, how it changed over time. And that was really significant. We are seeing a less than 1 estimate of the rate ratio, right? We're looking at 0.92 in the base model, 0.94 that adjusts for community level confounders, and then 0.93. So the model is pretty stable and consistent and significant with respect to how the outreach program can reduce the fatal overdose rates over time. Now, going back to the level, which is the first row here, there's no significant p-value. All the p-value is not significant, meaning that the program does not, as expected, does not result in immediate change of the fatal overdose rate. So these are two really consistent findings that as we look at initially. And now the second outcome, opioid emergency response rate, we are seeing the same picture, that there is no immediate change of the emergency response rates, but the slope change, they were all consistent and they were all moving in the direction that we expect. So we are seeing a very similar magnitude of the reduction, about 7% annually in terms of the both the fatal and also the non-fatal outcomes. So just trying to put these findings in some summary and a figure. So in this figure, although it looks a little busy, but we can focus on the two colors to begin with. Let's look at the red. The red dots are each of the quarterly rates among the towns that did not have those post overdose outreach programs. So as you can see, since they don't have it, the rates continue to increase over time, from 2013 all the way to 2019. Now, if we look at the blue dots, we have different gradients of blue dots. The lighter gradients are the gradients that establish the program later. Well, the one that is darker, the darker blue colors, are the ones that establish the program earlier. The earlier they establish the program, we can see that the bend of the curve, using the red line as a reference, starts earlier. Okay, and then that suggests that for the communities that establish the outreach program, the earlier they can intervene, the more impact they could have in terms of reducing the fatal overdose rates over time. And so I think this is a pretty telling figure about the timing and also the magnitude of these effects. So on average, we are seeing about 6% annual reduction of fatal overdose rates if they implement this program during this study period of 26 quarters, and no immediate decrease, which is expected. We also look at some other sensitivity analysis, which is also quite detailed, but what I want to focus is on a little bit on the within program factors. That means, we also want to know, not just having a program or not, but what type of characteristics that matters more than others. So we kind of differentiate between, how often they conduct the program, whether the program outreach is more intense versus less intense, whether or not the Narcan is provided, and then also some characteristics of the program. For example, whether social services, as DA Ryan talked about, it's really important to engage all kinds of social services programs. Many of them are health-related social programs, including education, legal counseling, housing, etc. So those are really important contextual factors that affect overdose. And if the program has those characteristics, will it be in a better position to reduce fatal and non-fatal overdose rates? So we did some exploratory studies looking at these within program factors. And what we found in general is that providing or referring to social services, they are, significantly associated with reduced fatality rates. And so we are in the process of publishing another paper that kind of highlight this finding. We also find that, the more intense the contact, and then the fact that they include harm reduction services, they are also associated with reduced opioid emergency response rates. So these are very encouraging findings that kind of describe what would constitute these kind of within program factors that may make a difference or better difference for suggesting better implementation of this program in the future. There are some limitations of the study that, these are not randomized. So there could be some factors that we have not yet control for, but, we cannot randomize this program in general in the real world. A lot of them depends on whether or not the community leaders, stakeholders, they see it as a necessary step to start building the partnership. So we have to, abide by what is realistic in the world. We focus on those communities that has 30 or more emergency encounters in 2015. So for communities that have lower level of opioid overdose, our study finding may not be applicable, but it's still pretty telling that it works. Yeah, those are really the main study findings. But overall, I just want to conclude that this program, they did contribute to the reduction of opioid overdose over time. And that is very encouraging by about 6 to 7% annually. And so, when this was published, people are very excited because, we have done a lot of work in Massachusetts, as many of you are aware that we have been, Massachusetts has been a pioneer in terms of combating opioid overdose, from early programs of using the community programs as a way to distribute Narcan and train bystanders, to standing order prescription at the community pharmacy level, to now really harnessing the community efforts in building partnership, conducting outreach, and many of these have important public health benefits, because not only it helps those who have experienced recent overdose overdose events, they also help people who are in those families, in the social network, to be more alert and be ready when it happens. So this really considerable public health spillover benefits from this type of outreach program. So I think that that pretty much concludes my talk. I just want to thank, really, it takes a village to write the paper. So there are a lot of contributors in this, what we call Pronto study, and it's still an ongoing portfolio of studies that our team here at Boston Medical Center and BU School of Public Health have been doing. And, in terms of how involved during COVID and how involved during the time when people tend to use stimulants in conjunction with opioid. So there's a lot more science that we hope to be able to uncover and inform and be able to work with community partners to avert, to kind of change the way that the crisis has been affecting us. So thank you very much for the opportunity questions.
Thank you. We seem to have a lot of questions in the chat. The first one seems to be about what you are able to tell us, Doctor, about the uptick in Waltham, what information you were able to get for that.
Yes, so I can let me write the note. I can follow up on that. The Department of Public Health in Massachusetts has this release of preliminary data of opioid overdose, and I just look at it. In the release, they said there were 2.5% increase compared to 2021, based on the 2022 data. And they also list a number of towns that had experienced substantial increase. And Waltham is one of the towns. There are other towns like Lawrence, Springfield, Lynn, Worcester, that is not in the Middlesex County, but they are listed there. There are some other towns that experience decline. So I'll be happy to identify the link and share with you. We don't know the specific of what constitutes the increase. This is something that I would love to hear from everyone about why that is the case. I can imagine the reasons could be quite complex.
The next question is, why are the majority of referrals, I guess in the outpatient program, to abstinence-based inpatient treatment? Do we consider medication as part of the treatment, or programs where there is medication given? Yes.
Yeah, so there are two main, you must be referring to this one. Sorry about this. Okay. Yeah, so there are really a couple of known intervention strategies. Providing patient education on Narcan and use is one, and then medical treatment has also been effective, particularly in terms of methadone and I believe it's naltrexone, and so those are the main medication-based treatment that that can be available, and methadone is inpatient, obviously.
Okay, the next question is to something I mentioned, which was about the marijuana laced with fentanyl. That, I would say, Jim, that's something we've been hearing from medical professionals, that people are seeing somebody come into an urgent care, an emergency room with what appears to be a fentanyl, having suffered what appears to be a fentanyl overdose, when folks are insistent that what they used was marijuana.
I think that's highly possible, because you know, the way that people can obtain marijuana these days can be so complex, and so that's why I alluded to it's important to have fentanyl test strip, and to prevent this, you know, super fatal substance involved in any contaminated fashion.
All right, the contact list, we'll send around a new contact list. Other questions that people have, and people can just speak out if they want to, especially if you want to refer to some of the information on the slides. Other people have questions.
I wanted to maybe jump in for just a quick second. I'm Allie Hunter. I'm here in a different capacity, but previously had worked on this study a few years ago. And my understanding when we were developing that language around abstinence-based treatment, that also includes detox. So I remember a lot of conversation around like what is included or not included in that, and what distinguishes that from outpatient medications for opioid use disorder. So I think there is a little bit of potential confusion among respondents, but that my understanding is that is what we would broadly think about as detox.
Mm-hmm.
Yeah, just wanted to make that clarification.
Thanks,
Thank you.
Dr. Hayes, could you talk to us a little bit more about your work on the deaths by suicide?
Yeah, so I've studied suicide basically my whole career. I always say it's very interesting, I think, because suicide is a public health problem, not because it's incredibly common, but actually because in basically 70 years of research, we have not gotten any better at preventing it than we were as I said, 70 years ago. I have a very interesting slide actually that shows all of the great public health strides we've made with regard to cardiovascular disease death, with regard to motor vehicle accident death. But suicide kind of is just less common, but not changing along the bottom. And I was involved in a lot of research. Starting in about 2015, I had a couple of big grants to do some machine learning predictive modeling to see if we could develop sort of constellations of risk factors that predict suicide. To be totally honest, a lot of that research, including my own, has not found much that we didn't already know about suicide and what increases risk. And I think part of the complication there is that to do that sort of very big machine learning suicide predictive modeling work, you need like really big population level data sets. And those typically are generated from medical data, like from insurance codes, healthcare use data. And the reality is any suicide is a combination likely of sort of longer term chronic mental health struggles and then more immediate precipitating stressors that, lead to the incident occurring sort of impulsively as it does. And one of the challenges to the field of suicide research in general is that we don't have data on the scale that we would need that combines both people's sort of long-term medical history with their more immediate stressors and things in their life that kind of made that moment feel bad and like the moment that this was going to happen. So I wish I had something very hopeful to say, honestly, about the field of suicide research and sort of like, we're moving in this direction and I think we're going to learn something. But I think that, the machine learning direction of the sort of last 5 to 8 years was a thing that people felt pretty hopeful about that turned out to really not yield that much that wasn't known. And so it's challenging. It's a continuing challenge to the field for a variety of reasons. The ones I just mentioned, because it's not that common, it's another reason you need sort of like these big data sets. There are not that many of those. You need prospective data on people's life before they die, usually. There's not that many data sources that have that, like great consistent capture of somebody's life before they die. So it's a challenge. There is a challenge. And as I mentioned, and I'm happy to share this paper, recently in the last year or two, people have been a little bit hopeful about the fact that it seems like overall the suicide rate is going down in this country. But actually, if you just dig a little deeper into race and ethnicity, you find that it's really mostly among white people is accounting for this sort of overall decreasing trend that we're seeing. And essentially among every other minoritized group, racial and ethnicity minoritized group, there is either they've stayed stable or increased in the last few years. So it's really, it's a problem that does not have like great solutions on the very immediate horizon. And one other thing I'll mention related to a point that was said earlier, there is a paper that shows that every person who dies by suicide, it affects 135 additional people. So related to this point of like, we need to bring in community, we need to bring in the context of people's lives. That's certainly been shown for suicide, that many, many people are affected by anyone's suicide death. And I have a grant under review right now, actually, that will examine family members, cohabitants of someone who died by suicide that weren't family members, to see what their long-term mental health and physical health outcomes are following that suicide loss. So, but I do think that that is a sort of less well addressed part of the public health crisis of suicide, is that, of course, the deaths are a tragedy and we should be doing everything we can to prevent those. But, it leaves this aftermath of orders of magnitude more people who potentially have long-term mental and physical health consequences to deal with for the rest of their life. And I'd be happy to say more about that if there's any questions or anything else.
One of the areas of potential partnership that brings to mind is, we respond, the state troopers assigned to our office respond out, even outside of the overdose situation, to any death by suicide that occurs in our county. Our numbers have increased in an alarming fashion. And it is obviously a balance we try to strike between a family that suffered that loss and how much intervention there is. And I would say across Massachusetts for many years, the balance was that law enforcement, once we had made that assessment, stepped back. And we, for instance, we do not speak publicly of that. Once we've made an assessment, we leave that to the family and to a family what they want to share with others, all of that. But we, in the last, I would say about 2.5 years, made a decision to change our practice regarding our advocates, our victim witness advocates, and they do now make contact in the immediate aftermath with families.
That's great.
To provide services, to, point people in the direction of services. So that is a place, that's a very large pool. And it's 1/4 of the state. That is a place, if there were minimally intrusive, a few questions that our advocates could pose. I mean, people would obviously answer or not answer.
Right.
But we could gather a lot of data. I mean,
Wow,
we
that's
make
incredible.
inquiry about children. We typically know, for instance, who found the individual. We respond to that. We are offering services for kids, for other families, because you're right, there's so many other people. But we would be happy to partner around that if we had, a handful of questions that
That would
people,
be-
it has been, I have been very surprised by the response from families really desperate to connect with us. I mean, there is still obviously some people who just say this is all private and I don't want to talk to anyone. And we are, of course, respectful of that, but the majority of people want to talk to the people who are calling them.
Yeah, and I'm sure we've all had the experience of how overwhelming it is to just find somebody to see for a physical health, or for anything, right? The healthcare system in this country is incredibly overwhelming. And in the midst of a crisis where you're devastated and maybe not functioning at your best, can you just imagine navigating our healthcare system to try to get somebody to talk to in the middle of that? It's, it seems like it would be such a challenge. So that's wonderful. I'll definitely follow up about that. Thank
Right.
you.
That would be a great
Best to
thing.
email you, or who would
Yeah,
it be best?
you can email me and then Madeline and I can figure out pushing that out there.
Okay, excellent. Thank you so much.
All right. The other thing, and unaccustomed as he is to public speaking, I know you mentioned your work with veterans, but we have with us Bob Cox from the Bridge Club. And he and I have been talking a little bit. They've just gotten some funds to help with veterans. And we are going to be working with them around our veterans court. We have one dedicated veterans court here in the county. I don't know if Bob, you want to spend a second just telling us about the changes, and then Doctor, if you want to respond to any of that piece.
Yeah, thanks, thanks, dear Ryan. Yeah, we're very fortunate to be to have landed this grant, and this grant is specifically for homeless veterans or veterans who are in danger of being homeless, who have been who are or have previously been incarcerated. And it's about getting them housing and employment training. We're very excited about it. We're bringing a lot of resources to bear specifically for this program in the terms of a specific IOP, which will be held a couple of times a week, possibly 3 if the need is there, specific to veterans at the Bridge Club. We have a veteran licensed alcohol and drug counselor who is also a licensed clinical social worker who will be working on staff, as well as a soon-to-be retired veterans, a VA person who's got extensive work with HR and a whole litany of experience through the VA directly, which is going to be a huge asset to this program. So we've got a lot of programs like a hire a vet program, apprenticeship, and a lot of kind of cool things that we're pretty excited about instituting. So that will be up and running. Where funding is in place now, but we literally just found out about it last Thursday. They were kind of late getting off the gate. So, the pieces are here. It's just a matter of putting them together. I'd say 30 days we'll be up and running.
That's great.
But we're real excited. And this is a 3-year program.
That's
We're
awesome.
funded for 3 years. So we're here to stay with this. So
It's
very
really
excited.
wonderful. Yeah, I worked at the VA for 14 years. That's
Oh,
sort of
terrific.
got my start in trauma and PTSD research. So it makes me feel really wonderful that that is happening. That's
Well,
really,
that's good news. And just as a matter of fact, this afternoon, we have at District Attorney Ryan's suggestion, we have a Zoom meeting with the judge who runs the Veterans Court in Framingham. And Mary and I haven't told you this, but Linda Dantas and I spoke this morning, and Linda has a connection also with the Veterans Court that she's excited about being involved with as well. So,
Right? Right.
really great, wonderful. And if there's ever, you know, anything that I could do to help the center, my connections at the VA, anything, I would be happy to think about ways to help. It's wonderful. that you're
terrific.
doing
I'd love to get your information. Thank you.
it. Yeah, it's on my emails in the chat. Somebody else had asked for it. It's just jgratis@bu.edu, but it's in there if you.
Okay,
If you-
great.
Well,
Thank you.
again, that's also a place where there might be room for a partnership around measuring outcomes. You know, Bob, like for us, right from the beginning, if we're sort of looking at how many people are we serving, you know, what kind of success, like how often are we preventing homelessness, all of that sort of thing.
Right.
So
Mhm,
we can connect around that.
that'd be great.
All right, any other questions for our guests today? Well, you've both been incredibly generous with your time and with your information. I'm very grateful. I'm very happy to learn about the center.
Thank you
So
so
thank you.
much. It was wonderful to be here. Thank you all so much for your work and these important initiatives and everything you're doing. Thank you.
Thank you.
Thank you.
Thank you both. Thank you, Doctor. All right. Now I turn it over to all of you. People have things they want to share. Anything upcoming? Thoughts? Anything else we can answer for people? All very quiet. Nothing going on? All right. Please reach out to us to get those strips. I so want to get those out in the community. So that would be a great thing. You'll be hearing more from us around this veterans piece. I am interested in that people who are dying by suicide piece as well. It's pretty alarming, the numbers that we are seeing. So hopefully that'll be a good connect. I remind you, our next meeting is Wednesday, August 9th. So we look forward to seeing you then. Thank you to Madeline for pulling this all together. Thank you all for being here, and enjoy. See you all soon. Thank you so much.
Thank you.
Bye-bye. Thanks, Carol.